very much. I wish our presentation was as dynamic as Katie's, but at least we're all awake now after that. So thanks for having us to talk today about our service initiative here in the Occupational Therapy Department in Our Lady's Hospice and Care Services. I'm Jane, and Aoife is here as well to present on behalf of our research team named above. So in the 15 minutes, we hope to cover a little bit of background and rationale for our study, give a bit of detail about the group intervention that we delivered, talk through our research process and the implications for practice, and then finish on one or two reflections from our group research process. So we know from a contextual background point of view, we know that both international and national guidelines, such as those from the European League Against Rheumatism, the NICE guidelines, and our own National Model of Care for Rheumatology, consistently recommend that we should have, that people with arthritis should have access to self-management education programs delivered by the multidisciplinary team. Here in the Rheumatic and Musculoskeletal Disease Unit, we do aim to empower individuals to manage their symptoms in their everyday lives to improve or maintain their quality of life. And within our own occupational therapy team, we have 4 skilled therapists, and we deliver both individual and group interventions based on the individual's needs and of the clients. So for those of you who maybe aren't as familiar with our role in this clinical area, some of the topics of intervention would include self-management education, and that would involve fatigue management, pain management, stress management, and joint protection as well. We have a strong focus on hand therapy here, vocational rehabilitation, so looking at either maintaining people in their work role, assisting people to get back to their work, or maybe exploring alternate avenues for their vocations. We also look at environmental and task adaptation, that's across all OT roles, and basically look at improving the person's ability to maintain their occupational participation, so whether that be in self-care activities, productive roles, or leisure. So the rationale for this study, we focused on one area of our practice, and it was a group we were running called the Joint Protection Group. And in practice, what we were doing was a 1-hour group, and it was accessible for people with inflammatory and osteoarthritis. The group was heavily information focused, so it was quite a lot of PowerPoint slides. There was a certain element of discussion based, and there was a certain element of practical demonstration, but we knew it wasn't really aligning with what the evidence was telling us to do. So there was a program developed in the UK called the Lifestyle Management for Arthritis program, and this was designed for people with inflammatory arthritis of less than 2 years diagnosis, and they attended over 4 weeks consecutively. But the difference was the approach they took, and they really had a much greater emphasis on skills practice, peer discussion, goal setting, and specific goal setting for the individual. And it came up with very good outcomes in terms of reducing pain, fatigue, and great outcomes for behavior change, so adhering to joint protection, fatigue management principles. Aoife had done a 2-day training course on the program, and I had done some further research as part of a master's on the program as well. So we wanted to look at how we could apply this really, well, there's the mismatch. We wanted to look at how we could apply this in our own practice. Here, I suppose we have quite a unique service in that it's an inpatient service, and I suppose people come for 2 to 3 weeks, so the 4-week program wasn't really going to be a reality. So we adapted the program. We utilized that educational behavioral approach, and we made it into a 2-hour lifestyle management for arthritis group. And we, instead of just limiting it to people with inflammatory arthritis, we invited those with inflammatory and osteoarthritis, and we didn't limit the length of diagnosis. So that was different to the program in the UK. The topics that we covered was around joint protection and fatigue management. I'm sorry, I didn't give it really an outline of what joint protection is. It's really looking at ways of reducing joint pain and swelling by altering the ways you carry out day-to-day activities, perhaps using assistive devices, looking at hand strengthening. So looked at that and fatigue management. And we had a much greater emphasis on skills practice. We went into the OT kitchen, we practiced the techniques, and we ensured a time for goal setting at the end, and time for discussing home programs as well. Much less use of PowerPoint as well. So we wanted to really see, how was this phase, looking in terms of effectiveness. So we asked the question, do participants benefit from a once-off educational behavioural lifestyle management for arthritis group? So that was our question. I'm going to hand over to Aoife to talk you through the research process.
Thanks. Hi, everybody. So for our methodology, first and foremost, we applied for ethics in both St. Vincent's University Hospital and ourselves here in Our Lady's Hospice, and we were granted same. We employed a multiple method sequential design, which consisted of 2 phases. So phase 1 was our quantitative data process, which was where we surveyed 47 participants using an outcome measure entitled the Joint Protection Knowledge Questionnaire. It does a bit like Rationale, it does what it says in the tin. It's a self-administered questionnaire that assesses people's knowledge of the strategies employed in joint protection. So we asked our participants to complete this before attending the group, immediately after the group, and then in a 6-week follow-up. As part of our quantitative design as well, we also included a feedback form. So we asked the participants to complete that immediately following the group. Our phase 2 was our semi-structured phone interviews, which was completed 6 weeks after attendance. And this was really used to gain greater depth into the experience of the group, which is kind of our second aim of the study altogether. We moved on to the data analysis, and our quantitative data was analysed using SPS version 25. And thankfully, we had the skilled experience of Dr. Mary Bell to assist us with that. And that was analysing the outcome measures and the feedback form. Then in our qualitative data, we used a content and thematic analysis. So that was a much lengthier process than any of us scheduled for. There was over 47 interviews, so there was a lot of themes and a lot of data that we had to trawl through, but it added a huge amount of depth to our findings, so it was well worth it in the end. When we look at our quantitative results, so we looked at the Joint Protection Knowledge Assessment Questionnaire. 35 out of our 47 participants completed it at all 3 stages, so before the group, immediately after, and then the 6-week follow-up. And we were delighted to see that there was a statistical difference between pre and immediately post the group. We're also happy to see that there was evidence of knowledge retention between the pre-group attendance and in the 6-week follow-up as well. So that was the statistical difference in the top one, and then knowledge retention in the last phase. As part of the feedback evaluation, 45 of the 47 participants completed that because we did it immediately after the group. They weren't allowed to leave the room, so they got it done. And 87% of the participants rated their overall experience of the group as excellent, and 93% strongly agreed that the practical session was helpful. So, I mean, both of those were very informative for us as skilled therapists, facilitating the group, that yes, we're making difference, but equally that new element that Jane talked about, the education behavioural approach, which was that group practical experience, was being rated very highly by the participants. Then moving on to our qualitative results. So after many weeks of trawling through transcripts, 3 main themes emerged. The first one was our positive influence of LMAG. So from that, we were able to see that the participants in the 6 weeks follow-up interview were really demonstrating that not only did they take on board a lot of the joint protection strategies, but they were then now employing them in their day-to-day activities, whether that be in an activity conservation point of view, or using assistive aids, or just changing about how they go about tasks. The group experience was the second theme that came across really strongly, and this was a huge benefit to us because, as we said, we moved to the educational behavioural approach, which was more discussion-based, peer learning, and that skills practice that Jane talked about. So it was great to see that moving from an information-led approach to that was really registering well with our participants. The third finding, the adaptation theme, was really interesting. We kind of looked at it in 2 phases. So from a newly diagnosed point of view, an early inflammatory arthritis, so similar to the Alison Hammond program, the early IAs were identifying the need to adapt their tasks or the way they go about things in their everyday lives in a preventative measure, so to reduce the risk of increased deformity or active disease. What we differed from in relation to the previous program, which we modelled it off, was we didn't put a limit on time of diagnosis. So therefore, we actually had a chronic disease model within our programs. And for these people, the theme of adaptation was that it validated their existing knowledge. So a lot of these participants had adapted out of necessity. They had to compensate through that lived experience, and attendance of the group really validated that for them. Yes, they're on the right track, and it also increased peer learning with our early IAs as well. So it was a really beneficial tweak to the program, we feel. All that led to one core concept, which we felt was empowerment. So people were feeling more empowered after attending the group, a greater gain of knowledge, and that they were all in the same boat and they had a safe space to talk. So moving on for implications for practice, the most important thing is that LMAG, the Lifestyle Management for Arthritis once-off group, is effective in our setting, which we were worried about. So we're still running it every fortnightly. We might do 1 week IA, 1 week OA, or sometimes we'll do a combined group depending on the cohort of inpatients at that time. The other implication was the benefit of peer learning. So as I touched on briefly in the adaptation, the participants really registered that they had a safe space to talk, that they were heard, that they were exchanging advice with people who had lived with that experience. And that really, they probably got more learning from that than maybe the skilled therapists. And then also for that chronic disease model, which was a new element in comparison to the Alison Hammond program, was that lived experience. So validating their knowledge and saying, yes, we're on the right track here, and even helping expand that a little bit further, because obviously people will move through the disease trajectory. So our reflections on the group research process, originally it was an OT-led project, and then around the thematic analysis point of view, we roped in Dr. Mary Bell because we thought she was going to do it all for us, but sadly no. She brought us into that, and in fairness, it really expanded the experience, and it really took us as OTs outside our clinical box and really outside of our own language that we're very comfortable with, and to really make that more accessible for anybody else to pick up a paper. The branding of the group is another thing that we plan to look at going forward. Lifestyle Management for Arthritis group, it doesn't exactly roll off the tongue. And we also noticed in some of the interviews that the participants were confusing it at times, not all, a small percentage, with other education groups within the unit, whether that be nursing or physio or CNS or anything like that. So we are in the process of thinking of a jazzy, catchy name. We're also really lucky throughout the process to receive funding for transcription of the interviews, which we hadn't factored in as well in our naivety at the beginning. So that really, as a working clinician, freed up a huge amount of time and hundreds of hours, I can imagine, especially at our typing skills. So that was a great support. Then future research going forward, if we were to replicate the study or expand it out, we would most certainly consider more outcome measures, in particular looking at fatigue and quality of life, just to broaden the study, add a little bit more depth and a bit more of the quantitative data as well. And there's the references in relation to Alison Hammond, the original program, the model of care, the NICE guidelines, and then EULAR is available on the website as well. Any questions?